Actually, yeah. So thank you everybody who's joining us here, and we're having PG filtered in online. Just to remind everybody, these talks are hybrid, so you can always join virtually if you can't make it in person, and they are broadcast on Facebook Live as well, so you can just come and listen in, and you can see the recording there as well. This is Science by the Slice. I'm Fenella Saunders. I'm the editor-in-chief of American Scientist magazine. These talks are put on in collaboration with Science Communicators of North Carolina, who helps us book and plan the events and book our speakers. We produce blogs out of the events that are posted online afterwards if you want to go back and look at any material. We also get funding from the North Carolina Biotechnology Center, who provides our pizza, so thank you to them. And also the RTP chapter of Sigma Xi. So thanks to all of us for working together to make these events happen. Today we've got a great talk from Christina Cruz, who is an assistant professor and has expertise in medicine, business, and education. She completed her medical and education degrees at Harvard, her undergraduate business degree from the Wharton School at Penn, summa cum laude. She completed her general physics residency and child and adolescent psychiatric fellowship at UNC. And she founded and is the principal investigator of the Global Child Mental Health Collaborative at UNC. So just go ahead and get you started, Dr. Cruz. Thank you very much.
Thank you. Thanks everyone for coming today. I'm excited to be able to share my work. And it's the work of two other really large groups who work with me, mainly an NGO in Darjeeling, India called Darjeeling Leyden La Robe Prerna, who's been there for about 30 years doing sustainable ag, environmental issues, and now school health and mental health, and Broadleaf Health and Education Alliance, which is an NGO based out of Pennsylvania, focused specifically on Darjeeling and school health. So I'm here to talk about task shifting child mental health care to teachers today. I'll define all of these terms in a moment. Essentially what's happening is that we have figured out a way to build up teachers' skills in mental health so that they can support students in all the movements that are already happening in the classroom. Now they have evidence-based tools such as from cognitive behavior therapy, CBT or dialectical behavior therapy, DBT or behavior activation, all evidence-based therapies to use in those moments. Teachers see it as themselves having new skills. As an educator and a child psychiatrist, I actually see it as care. And what I'll walk you through today is the evidence to show that children in fact improve. All the pictures I'm showing today, including this one, are ones either I or my collaborators took in Darjeeling. They're both to kind of illustrate just like what it looks like for us, like have you envision what care might be like in these settings, and really to also highlight the resources that are available locally. So you'll notice like the kids are all uniformed and really excited, and perhaps that the tables are handmade, the walls are in part makeshift, and the windows a little bit crooked. And so that's just to give you a sense of the resources available and why teachers might need to be tapped to help support child mental health. You can imagine there are probably not many child mental health clinicians there. So I have permission to show all these pictures just so everybody knows. Okay, so to set the problem, access to child mental health care is poor globally. There are about, you all probably know this, but I'll reiterate, about 1 in 5 children globally, and this was actually pre-pandemic, have a mental health condition. 90% of children do not receive care, which is considered a large care gap. Access is particularly poor in low and middle income countries, where much of this work has been. There are more child psychiatrists, myself included, in the state of North Carolina, so about 354, than in India, which has 73, and the Philippines, which has 60 combined. So that speaks to the access level globally of child mental health, specifically here, just highlighting child psychiatrists as I'm a psychiatrist. Other facts, like again, illustrative statistics are there are more child psychiatrists in California than in the continent of Africa. So again, to highlight where the access is. And then with COVID, the youth mental health crisis has really just come along with it. It's worsened the need for care. Estimates are still kind of coming up, but we think it's possible that prevalence has doubled. So maybe 2 in 5 children We also know in some areas it can be almost up to 60%, depending what's happening. So it might not be the fully, classic major depressive disorder, but it has that flavor and is impairing such that for sure it's a mental health concern. So we need to think about alternative care ways to get care to kids. I focus on kids as a child psychiatrist, in part because there just simply aren't enough professionals, as I've highlighted in the previous slide. So we think about task shifting. In task shifting, professionals are trained and coached, are training and coaching community leaders to deliver the tasks of care. We call these community leaders lay counselors. So we know that task shifting helps improve adult mental health symptoms. We think it improves it for adolescents. And the way it works is that professionals will level training and level therapy so that they can train and then supervise basically anyone in the community, commonly community health workers in low and middle income countries, to deliver care. This is really pioneered in mental health by Dr. Vikram Patel, who's now out of Harvard. And it's a lot of his work that's actually been showing in adults and then some in adolescents that it may improve symptoms. One gap right now, though, is for children. So lay counselors rarely have the child development experience needed to deliver care to children. You can imagine that a 5-year-old might look quite different from a 12-year-old. And most people don't have that kind of working knowledge of the differences, even as I'll say myself as a parent, who even as a child psychiatrist, I still surprise myself in remembering what my children are capable or not at certain times in their lives. And so I posit that teachers might be able to serve as lay counselors. Importantly, they have the crucial child development experience, even if not learned in their own training, through their everyday, where they're able to say, I know children are capable of this and not this. They have daily access to children already through our societal organizational structures, schools, and they have more access to children with mental health concerns than most. So they're not going to have, unfortunately, access to all kids with mental health concerns. We know worldwide that of the kids who don't access education, a majority of them, it's because of a mental health concern. That being said, more and more children with mental health concerns are beginning to enter schools, actually since 2000, as stigma is starting to go down and as schools are more able to accommodate children with mental health. Finally, teachers have been shown to be able to deliver targeted therapy for targeted diagnoses. So as a little background, therapy tends to be very specialized. So you have like CBT for depression, and that will be different from CBT for anxiety. It's a different set of skills that the therapist has and is working with the client. You can imagine, though, that teachers, this would be their second job. And so they've got a lot going on. And so there are barriers to them being lay counselors. They feel undertrained to work with students with mental health concerns. In the US, it is not part of teacher training to know how to work with mental health concerns, and certainly not globally. Some may not view students' mental health as their responsibility. To my first point, their first responsibility is teaching, though I would say that a growing cadre of teachers also see mental health and are starting to take on that it's the child's growth that's part of what they do. Even if perhaps politically and otherwise, they might be judged for certain academic achievements. They report already being overburdened with teaching. We know that here locally in North Carolina, and that's true globally. And then because of the way therapies are structured to be per diagnosis, they really only have time to learn how to care for 1 to 2 diagnoses. They're already teachers doing a lot. And so to ask them to take on more might be too much. But it felt like a nut I could crack. When I was in medical school, I was taking a year off after 3rd year to get a master in education. I really wanted to think about how schools could be platforms to improve child mental health. And at the time, my med school classmate, who is Broadleaf co-founder, one of the NGOs from the beginning, approached me knowing I was getting a master in education for the year. He was starting Broadleaf in Darjeeling with his wife, Denna, and they were targeting school health. They were teachers there before medical school, and saw the value of schools being a platform for health. But with that 1 in 5 prevalence, they also knew mental health was coming up in the classrooms. So together, Mike, Den, and I thought about like, how might teachers be able to do this? And while they were starting their NGO for the year, I was thinking about this problem in education school. And by the end of the year, we together came up with Tea Leaf Manasik Swastha, which is teachers leading the front lines mental health, Manasik Swastha being mental health in Nepali, the local language in Darjeeling. It is a system of care that's task shifting, where teachers are trained and supervised to deliver care. The care is something we invented called education as mental health therapy. And I alluded to, it's not a traditional therapy in the sense of having a manual and sitting down with someone one-on-one to do care. It's what the teacher does in moments they already have with children. And so I'll get into exactly what that looks like. First, to go through the facilitators and barriers and how Tea Leaf and EdMH, Education as Mental Health Therapy, might address them. So through Tea Leaf and EdMH, there's 1 week of training and twice monthly coaching, which gets to teachers feeling undertrained, but also capitalizes on their child development experience. They learn to teach and be therapeutic at the same time, and I'll get into an example of how that goes. But this is a way to address when teachers feel like mental health is not their responsibility. They can address it with something they're already doing, and that seems to go a long way. They report already being overburdened with teaching. So again, this is back to, we created something that they can use in already occurring moments they're having, or in planning they're already doing anyway because children are having concerns in the classroom. And then EdMH is something called transdiagnostic, where it's a kind of therapy where the principles are the same and can be applied across any diagnosis. So different from how therapies are currently laid out. The way we do this is by thinking about behavior and motives. And so we characterize behavior into essentially behavior analysis 4 motives. There's attention, escape, tangible, and sensory. And so regardless of diagnosis, you can imagine, you can think about a child's behavior, where it fits into that, and then pick measures that go after the motive. So again, depression, anxiety, trauma, it's all kind of the same in a way. So to go through what this actually looks like, I'll first talk about teaching and then what EdMH might look like in practice. So these are real cases. I've changed names and I've kind of mixed up the pictures, so it's not all the same children. But the case is, both of them are ones that I've seen myself in Darjeeling. So in this first case, Arpana wants to share her work first after the class did individual classwork. She's asking her teacher to do so, but the teacher, as teaching as usual, tells her to wait until it's her time, until it's time to share it all. And that when it's time to share, she can raise her hand and she might be called on. So I point out here, this is typical. What you'll notice is that it's an undefined amount of time, which might be hard for a kid to understand. And then there's an unclear outcome. Will she even be called and what's going to happen? So in this case, I saw Arpana disrupt class. She didn't finish her work. This is not an uncommon punishment in Darjeeling. She was kneeling in front of the class and she didn't learn a new behavior. And you can guess that her mental health wasn't really addressed with that measure. It's kind of hard to see in the room, but you might notice that her hands are actually over her ears because the children are also taunting her for being punished. And so this is kind of how this played out, teaching as usual, this first scenario. Then we go into education as mental health therapy. What happens when the teacher has those techniques that that Mike and Dana and I invented? It starts with Roshan here, and now Roshan wants to share his work first. This teacher is Tea Leaf trained, so she now uses 2 different techniques. First, she tells Roshan to wait 2 minutes and that he'll be the first to share if he waits. So she's now trying to increase his distress tolerance by giving him a very defined period for which he has to wait. And so he sees the end. Then importantly, she says, he'll be the first to share if he waits, and if he can't wait, he cannot share his work. So there's both a clear reward, meeting the need, but also a clear non-shaming punishment where I told you if you couldn't do this, you can't share your work. And so in this case, this was after the teacher had had Teely for a while. Roshan completed his work. He's learned to wait, this distress tolerance, and then new behavior is learned, which is that if you are able to wait, you might be able to have your need met. There are different iterations of how a teacher would use, say, this kind of technique. Obviously, it might not work all the time. She may need to repeat it many times in a row. But the point is, you can see these distress tolerance for a defined period. That's very DBT. And then the clear consequences in our way, a little bit of CBT, a little bit of behavior activation. And so we've distilled these concepts into what teachers can use in the moment. So how does this actually end up with kids improving in their care? So this is typically how a teacher might be able to improve a student's mental health. Usually, you would think about a therapist directing a teacher how to interact with the student. Said student has anxiety. Teacher, I've been asked to talk to you about ways to help this student when they're having moments in the classroom. In under-resourced areas, though, including in a lot of North Carolina, there aren't therapists, but there are mostly teachers. So this is where Tea Leaf steps in. Tea Leaf trains and coaches the teachers to think like how a therapist would think. And so they themselves determine the interactions that the therapist would have otherwise told them. And so this is, again, simply an extension of what would have been the ideal. This time, though, because there's no therapist, we've replaced the teacher to have that kind of mindset and ability to choose. So the evidence for Tea Leaf. I cut this short in the interest of time. I actually have the slides later on the graphs and the different actual evidence for this first piece. But needless to say, teachers have found Tea Leaf and NMH to be acceptable. This was across 24 teachers in 2019 with a quantitative, it's a mixed method study, so quantitative and qualitative together, where a lot of what they found to be acceptable was that they were working towards improving student mental health, and they were able to flexibly use Tea Leaf as they saw fit, as opposed to it being prescribed. They saw it as feasible, and this was the paper where we described that. This is from a 2018 study. It was also mixed methods. And essentially what they were talking about was the same of what was underlying acceptability, which was that because it was designed to be how they already interact with students, and even things like I didn't quite bring up, but we have them create a behavior plan for students. It's stuff that they already do. And so we've simply tweaked it to be couched in CBT, DBT, and other therapies. So they found it feasible, and it was simply a different way of doing what they're already doing. And then they delivered Tea Leaf and NMH with fidelity. So there are more findings in this paper, but essentially with fidelity, we use the benchmark of about 60% fidelity to protocol, where that is about the benchmark you would use for a mental health therapist learning a new therapy. And across the different domains, they had a fidelity of 60% or higher. This is a busy slide, but importantly, what I'm about to show you is that it turns out Tea Leaf works. So we, happily for me, so we have two different measures here. The teacher report form and the OSSER, which is an academic achievement measure standardized to rural India. The TRF is by the ASEBA group, and it's a way for teachers to input what they see happening in the classroom for children. And the output is a number of different scales that are related to the DSM or the diagnoses, as well as severity. So the first I'd want to highlight here is in this finding where we compare, this was as COVID was happening. So we did a quasi-experimental comparison of a pilot trial of Tea Leaf where we had 24 students. And then actually the first step of our stepped wedge efficacy trial, where all were control. And so there were 188 students. And so they weren't randomly selected into either. And all children would have received Tea Leaf at some point. Our effect size when you compare the TRF with enhanced usual care control as reference is 0.7. So medium to almost large in terms of improving child mental health. The other way to interpret that is if you dichotomize the TRF into neurotypical versus borderline clinical, where borderline clinical means child needs care, needs medicine or therapy, the relative risk of still having clinical level symptoms after tea leaf is 0.44 compared to EUC, or in other words, approximately like 56% of the children, their symptoms were completely alleviated. And that's, you know, for reference, SSRIs like Prozac or Zoloft, that rate's about 1/3. So this is almost double as effective as an SSRI for these children. The final one I want to highlight is the effect size on academics, where we were, to be honest, a bit surprised it was this high. But what we found when you compare the OSSER in math and then reading, the effect size is 0.79 for improving math for kids in tea leaf versus not, and then reading 0.844. If I didn't quite put a square around it, but if you look at the crude beta estimate, each point is about 1 grade level. So in math, kids do 2 grade levels better in tea leaf than EUC, and in reading 1 grade level. So with these findings, they've set the stage for us to do a number of different things in research. In Darjeeling, we're funded by the Mariwala Health Initiative, which is a foundation that works towards improving mental health equity in India through research and implementation of programs. They're funding our type 1 hybrid effectiveness implementation trial that had started in 2019, and we had to restart in 2022. These results have gotten the eye of administrators in Manila, in the Philippines. And so this year we're piloting tea leaf in 5 schools in the public sector. And the plan is to scale it to all 73 schools of the city, which should reach about 20,000 children. Finally, in North Carolina, we've been adapting and piloting it to the middle school and rural North Carolina context. This is supported by the UNC Suicide Prevention Institute, which is funded by the Starling family. And we anticipate doing an RCT next year. To get into a little bit of each of the 2 other strands of research. In Manila, right now we're teaching 50 teachers, and they're in 5 schools and 5 guidance counselors. So what we're doing actually is building up the model for scale, where right now the supervision is coming from our team of social workers in Darjeeling. That's obviously not possible at scale. And so we're teaching guidance counselors, or they have this hybrid guidance teacher to be the coach. So we're developing the cascade or train the trainer model right now. And that's what we're going to be doing an implementation trial alongside scale afterwards. The pilot trial is foundation funded, and we're in the process of applying for NIH and foundation funding for the scale and the implementation trial. In North Carolina, we're in the middle of adapting this tea leaf to the context. We have 1 school that may not be able to work with us this year, and so we're actually actively reaching out to schools for the spring, which is a harder time, but to see if anyone else might be interested in partnering with us to trial tea leaf for the spring. And then for the next year, we have a plan for an cluster randomized control trial to be able to show that this works in the North Carolina middle school context. So these are kind of my lofty goals that I just like to put up as my dreams as I've been doing this work. In Manila, in the short term, we're going to scale to something between like 20 to 50,000 children. 20,000 is the lower end, assuming a prevalence rate of 1 in 5. 50 is closer to the 2 in 5. There's also a plan for government uptake given the costs, as I've outlined here, where right now the research costs of tea leaf being implemented, which is actually higher than what it would be just implemented, is $148, but this is the best estimate I have right now. The average cost per child per year of mental health care in the Philippines is $917 US. And the average Philippine government payment for 1 hospitalization is $154. And so there's talk right now, as I don't think I highlighted it, where one of the assistant secretaries of education for the Philippines is watching this Manila trial and is considering a nationwide scale should Manila go well. In Darjeeling, we're looking to scale right now to at least all the low-cost private schools where we've been, which is about 10,000 children. We're also targeting government schools, but the process is a little bit different than it was in Manila, so that's a longer-term vision. We're expanding to include neurodiversity, which includes developmental disabilities, autism, and ADHD, and that while TLEAF has been transdiagnostic and is transdiagnostic, what we've also found is that cases for the teachers that have been the hardest have fallen into these categories. And so it's not that they don't already have the tools for working with these children, but we haven't taught them like the mindset of how to understand attention escape, for example, in these children and what might work given their neurodiversity. And then finally, we're expanding in Darjeeling to adolescents, and that's been funded by the Doris Duke. In the US, next year is the planned RCT. Medium-term future work, I talked about Manila and Darjeeling. So in the US, after the RCT, we'll be applying for an R1 for an implementation trial to show how to scale it here. I think it's gonna be a little different than Manila. And then we're planning to offer it to all counties in North Carolina as part of UNC Prevention Institute's collaboration right now with Carolina Cross 100 and really focusing on suicide prevention in the state, particularly for youth. And TLEAF is seen as kind of upstream suicide prevention with addressing mental health. And then finally, my long-term future dream is that TLEAF is just part of teacher education globally. And that's the feedback we've gotten from a lot of teachers, is that they just wish they had gotten this training in their training. So I'd hope to reach something like 85 million teachers one day, or be able to treat 1.3 billion children. That's the lofty, lofty goal. I do think, though, these kinds of changes, maybe not that big, but getting into teacher education, I think is a reasonable goal given the needs that we're seeing. I couldn't have done this without the Child Mental Health Collaborative, which is my group at UNC. We focus on creating alternative systems of child mental health care. This is my UNC team. We work with Broadleaf Health and Education Alliance, which I talked about, collaborators at the Colorado School of Public Health, where Mike Maturgis, who co-founded Broadleaf and has been with me this whole time on team, and Dr. Sennett at the University of Houston. We try to be multidisciplinary and think about care in a number of ways. And one of them is through anthropology, given that the context is so different for the care. In India, this is only possible with DLRP. And I failed to mention Priscilla Geary in the beginning, who is one of our co-inventors. She has been with us the whole time and has made TLEAF work. And we also have a number of other social scientists and anthropologists on the team in India. These are our citations, and that's it.
Do we want to ask any questions, or?
Yeah, I do have some questions because you want to expand this. Are you hoping if you do the clinical trial, controlled trial in the States, to get enough information to maybe start like a class in, when people are going for their teaching certificate and stuff? Is that the ultimate goal? To be part of the plan, right?
That's my goal. Yeah. Yeah. I think that would be the ultimate goal, and that yes, because I think some schools of education do have like classroom behavior management classes or fun things, but it's not robustly taught necessarily and consistently. And so this would be an evidence-based way for them to do that. That's the goal. Yeah.
Okay.
But again, I'm nowhere close to there.
Right.
I'm wondering if you can talk a little bit about your method here, because you mentioned that it's related to cognitive behavioral therapy, but I'm still a little unclear about what your actual teaching process is. What are you teaching these teachers?
Sure. So great question. So what we're teaching the teachers is essentially, like, I can boil it down to 3 things. It's behavior theory. So to understand behaviors through a psychological lens, and then behavior analysis. Once you understand kind of what's going on with the behavior, get into the nitty-gritty. So we have them observe children or write down 10 observations they've had in class of exactly what happened in the CBT way, in the BBC chart. time, what happened before and after, then they start to see these patterns. So it's not just attention, but it's attention during unstructured time when Christina can go off the rails, right? That's what they start to see. And then we have them create a behavior plan that is CBT mostly based, where we give them a list of options they can use that are CBT, DBT, behavior and activation based. And they then say, okay, Christina's acting up in these transition times. What can I do in those transition times that will meet her needs? And it's give her a leadership role, give her praise for that. And as she's better able to do that, she gets more rewards, that kind of thing. And so that's what we're actually teaching them in the training, are these specific tools that they then go and use in the classroom. And then the key to task shifting and really any therapy, any intervention, I think, is coaching or supervision. So then once a month, our team will show up to the school to discuss their cases. How's it going? As part of research, they do monitoring of fidelity to see. So that's how, these are the specific tools that the teachers learn how to use. And that's the CBT, DBT are from that list of options that they can choose what to do.
Okay.
We'll answer the
Yeah,
question.
that helps. Thank you.
Okay.
You have other questions? Go
So I
ahead.
have a similar question what she asked. So, since you're talking about those CBT and DBT tools and, I was also a little bit interested about looking those numbers, from a quantitative analysis or mixed method researches, right? So my question here is do we have, any of those open-ended questions, that you can not just for the sake of training the teachers, but make the same instrument be reusable, from time to time, because these cognitive behaviors, won't have a similar pattern over
Sure.
a period of time because they can go up and down. So do we have any such instruments, that teachers can track on a daily basis, weekly or monthly, see how this kid is performing, either he's dropping low or coping up, and that data speaks more about what sort of service that we're providing versus what we expect, right? So that's an evidence-based thing. So do we have any things like that, where you can keep a track of that data from time to time, from one region to another region, do the comparison studies, and then it's more of a normalized process, not just a one-time thing saying, hey, you know what, this is what we're trying to implement as a part of BT Leaf, and pilot is done, we're done with it. No, this is an ongoing process, it's a continuous, right?
Sure, yeah, and apologies if I didn't fully grasp the whole question. So there's nothing, so we have set up symptom measurement pre, mid, post. In the meantime, teachers tracking how the children are doing, we don't collect. We do have forms for them to do that. Already I'll say, I don't know, have you worked in schools before?
Not yet.
It is impossible.
I experienced a little bit the same because, while I was doing my PhD dissertation, and I want to, get these surveys collected from teachers. And I reached out to almost 700, teachers and school principals, entire NC. And I got 4 responses back saying, maybe I need to.
Right. That's my point. And this is not tongue in cheek, teachers are busy people with a lot on their plate. And so we have tried to minimize data collection as much as possible. So what we've instead done, it's not quite what you're talking about, is we do encourage them to revise the behavior because it does change. And so it's not quite quantitatively perfectly sound. Qualitatively, we are able to see these changes because we can track these plans and code them. And so we can see that for some kids, it only takes 3 months to improve. And for other kids, it's this up and down thing. And it's because we can back out from the behavior plan what measures they've used alongside the kid's diagnosis to see and the severity pre-post to then understand what might have happened in them. But I would love to do that. There's a lot about this research that honestly is incredibly messy, that does not, I don't think the standards of RCTs are honestly really feasible in schools. It's just not, for many, many reasons, possible. So we're doing the best we can with this pre-post and
You're
backing
already
up.
dealing with a resource strapped situation, which is why you're doing this. So.
Yeah, and I will say that like schools, you can convince them of like equipoise, and they like need to get their kids better. So if you're gonna put them in a control, they're not really interested in just giving you data, right? Or like we had to do enhanced usual care in part because it's ethical in a setting where there's just no care. So we can't just identify kids and then let them be with mental health concerns. And so even then we're supporting the teachers in this other way, but there are just all these practical concerns, like when can you fit in the training? When can the team come where not all the teachers are running around trying to do all this stuff, right? Like, but it is to us important because it is the real world setting. And if we can show in the real world, as messy as it is, that this works and is possible, then it actually is applicable.
Right, yeah. Did you want to ask your question?
Oh, yeah, thank you very much. Topic I'm really interested in, and that topic reminded me a small essay I wrote 5 years ago. I like to share the point and then I ask one question. So this actually, I realized the mental case, the mental issue problem long time ago. That time I read the paper and read the essay about this called excessive screen time in the brain.
Excessive screen
Screen time
time
in the brain.
and the
In the
brain.
brain, okay.
Yeah, and the point here is decrease sleep quality and promoting sedentary habits and decrease brain functions and change biological clock and change brain waves and reduce the neurotransmitter restock and essential nutritions and change brain region with the different function. Basically, I wrote here, basically some scientific published papers. And the problem with this screen time, something that's caused the case, the mental issue. I believe that could be big issue we may face right now. And so like the teacher, my question is, like the teacher in school can do something with that challenge?
With screen time.
Yeah.
That's a really hard question, I think. Is there something you would like when you wrote the essay, was there something you were envisioning or something that you had thought of?
That time actually my kid at school, sometimes I all the parents want to kids take all the attention on the studying, something like that. And also you have opportunity to meet another case from another one. You could also, based on the media, this could big issue use cell phone or the TV and all.
A lot of classrooms use screens now too.
Huh?
A lot of classrooms use screens
Yeah.
during the day.
Right.
So it's almost incorporated into, at least in this country, in the educational setting. I'm not sure in Darjeeling if they're using screens in the classroom.
Hopefully, no.
Yeah. Yeah. But I don't, did you have any comments?
I think it's like a larger societal issue. I think schools can absolutely contribute. I'll say like my children are school aged right now and they use a lot of screens in the class. And I think schools are very cognizant of that issue. And so for them, it really comes up as a learning tool as opposed to it just being there. And like my older child, they're not allowed to have tech at all in school. Only the tech that's being used in the classroom, which is essentially like a laptop or a little iPad or something like that. So I don't have a good answer in that. It's not like this where the teacher can change what they're doing per se, and like the child goes from needing medicines to not. I think that's a larger cultural problem that we have where I will say, like, personally, we don't let my children are not on screens, because I also think that there's a contribution to grumpiness and all these other changes in brainwaves. But I think it's more of it has to be like a community concerted effort to do that, which includes trying to fill, say, children's times with other activities or just some place that's tech-free. Like, I don't know that there's anywhere around individual parents making choices.
Yeah, it's such
Yeah.
a problem right now, I think, as much as anything.
Yeah, it's some school, right? You can
Yeah.
decrease it in school, sure, but as soon as the kid gets out of school, like,
Yeah.
it's on the parents. Whether they have any control, that's different, but it's
Yeah.
on the parents to be able to, I think, make those decisions. We can try to support it as like a state, right, by providing more community structures that take that away, such as like, let's encourage everyone to do arts, sports, whatever, or whatever else to fill the time. Because I think otherwise, like, in my mind, tech is like incredibly smart in tapping into like the human need that it's filling. And so it's really powerful. And so you really, I think, would have to fight it kind of societally.
Yeah.
Yeah.
Well, we can try to ask more about this later, but I did want to just bring up one question that somebody had asked related to burden on teachers.
Burden on teachers, yes.
Because they're, the concern is, you've mentioned this, teachers already are overworked. Have you had feedback from the teachers, I guess, related to, do they feel like so right now in schools, my kids are in public school here too, and they're 10 and 12. And it's really, I think, shifted so that if you do have children with behavioral problems, the teachers are basically mandated to figure out how to keep those kids in the class and not send them somewhere else.
Sure.
And so they're already having the burden of dealing with children with behavioral problems. So have you had feedback about, teachers who already have to deal with behavioral problems? They feel like this helps them manage those problems?
Yes, good question. So I think there are three different contexts to discuss. I'll hone in the US, which is, the answer is essentially yes. There is, if we're going to talk about burden, the burden is the initial training that takes time. Once that's done though, when they're starting to use the skills, the teachers find it helpful. So it's no longer burdensome. They might require a little bit of a cognitive load of, right, I would have done this before, now with tea leaf, I should be doing this. But by and large, as that also starts to click, it's second nature. And so to back that up in Darjeeling, I didn't go through the findings here, but a lot of our qualitative work shows the same, where like it's qualitative, so I shouldn't put a number on it. And like a large majority of teachers find it helpful. Not everyone will. And if I were to guess, maybe like 5 to 10% said, like, this is still too much for me. I can't think about what to do in those moments. I'm just going to do what I'm going to do. That's fine. Like, that's how you have to work, right? And so, but for a large majority, they're able to make it second nature. And actually part of our study right now with anthropology is to see how has the school changed in culture, and and this has been brought on because the schools have come back to tell us, this is just now how we operate. This isn't a program. This is school culture, which has been lovely. So I think there's a potential to get there. It's just the initial hurdle of training and buying in that it will be helpful. Right. But yes, it ends up being helpful in those moments where this kid's going to be in the classroom no matter what. How am I going to manage this child, attend to their needs and everyone else's?
Right. Yeah, because they're already being given that. Like, they're not being given a choice in that.
Right. And so you have to work with it, right? And so the other thing that we found, and we haven't quite studied this, is that teachers will use this for all the kids actually, because it's not, there is of course the 1 to 2 to 4 children who really are needing their behavior to be targeted, but the teacher doesn't just stop. And so it actually bleeds, which is really nice. And so they sometimes make it like whole class, like everyone has to learn to identify emotions or whatever it is, or like everyone does a mindfulness thing right now. And that also in Darjeeling, it happened honestly in part to not stigmatize mental health and single out the kids who might need it. And so everyone just got it. And what we show is that I don't individually, because neurotypical kids, it's kind of harder to measure when they're more neurotypical. So they don't change, but that's good because we were also worried that perhaps attention to kids with behavior issues takes away from the other kids, and it doesn't. So yeah, sorry, that's a little long.
No, it's all good data because basically, I mean, even after the pandemic, I think all kids, whether or not they are actually at the state of needing mental health care, a lot of them have like low level anxiety and things. And
Yeah.
all kids have behavioral problems at some point or another, even if they're perfectly normal, you know. So,
Oh, totally.
yeah.
Or even just like, I like to say, like I trained as a child psychiatrist. I sometimes tell this to friends and family, like, I can't believe everyone didn't train like this. Like, this is just how I think about people.
Right.
It's whether or not there's a mental health concern, like people have needs and like, how do I support someone and do it in an authentic way? It's, and that's how I think about it generally.
Do we have any other questions?
One last
Yes,
question.
go ahead.
So, of course, since you already mentioned two key points here, burden and culture.
Yeah.
These two play a big role, like, in deploying the CBT or DBT based tools in these organizations or in these locations, right? And one key finding that I observed, like, from your studies is like, you had these pilot studies deployed, like, in two different zones, which is completely the other side of the world. So do you find any gaps, challenges, or ways, that made you think, okay, there is a bit of cultural difference, in these two areas, and you cannot deploy the same, CBT or DBT, in one zone. It needs to be customized based on the cultural need or something. So do you face any experiences like that?
Yeah, definitely. So I would say we started in Darjeeling, India, and then moved to Manila was the next one. And so there are already differences in how children perceived and what the behaviors were actually. So we did have to adjust. I wouldn't say it was even the measures themselves, because they're pretty non-specific in a way, but nevertheless, we would make sure that we knew that certain ones were more likely to work well. So for example, in Manila, this isn't even culture, it's like structure. There are public schools, the way we think of public schools here, multiple classrooms, principals. In Darjeeling, sometimes it's 3 grades in one room and that's the whole school, right? So in Manila, we were able to deploy more of these, like separate the children and like have one do this thing and the other do that thing. Whereas in Darjeeling, it's not possible. There's nowhere to go, right? So those were really important. And I will say now in coming to the US, what's been really interesting is that, I don't know how to say this right, but this is how it was explained to me in the Philippines, is that in the Philippines at least, and I have some background, teachers are like really revered. And so the amount of like behavior concerns that comes up looks really different. It's more of like verbal disrespect, whereas like in the US, like we've heard of teachers being assaulted, and that just doesn't happen in the Philippines, really. It can, but I would guess it happens more here, just anecdotally based on our having to adapt it. So we do have to adapt. We talk more in the US about safety because it comes up more. But I don't know that it's all in there. It's just like what's more emphasized, if that makes sense. Because I grew up American and I'm a psychiatrist from America. And so that was the lens I initially had. And so it's kind of come full circle.
Yeah, that's where I got confused, like, from the cultural standpoint, it may not be a big difference between Darjeeling, India, and but it may be, there are a few differences there because of 2 different countries. But compared to India and here, or Philippines and here, it's a lot. And we had to go through a lot of adjustments, like, making all these updates, like, before even we asking the teachers, like, to adapt these changes.
Right. Yeah, and I'll say like what was just fascinating for me to think through just in terms of the arc of history is that I don't know how much you all know, but the Philippines was colonized by the US for 48 years after the Spanish 300+ year colonization. And so Manila was almost a step for me towards the US, where it was like a hybrid of like US settings and Southeast Asian settings, which is closer to the Indian setting. And so it's been like this, and it wasn't on purpose, but I've been able to kind of get back to the US in this measured way of seeing like how would it change, such that, for example, public schools look the same.
Right. Interesting.
Thank you.
All right, if we don't have any other questions, you can come up and talk to the speaker afterwards, but we'll let everybody close out. Okay, so thank you so much. Sure that this stops.